Do you mind if I open your GYN list?
Yeah, that'd be great. I'm a complex family planning fellow, so my entire list is DNCs and DNEs. So I would just be curious what kind of questions you can see being asked based on those very specific types of procedures.
So I think since there are some people who like are Urogyne and have only Urogyne, and some people who have just this, I think they're gonna deviate a little bit. They
Yeah,
can't spend the half hour talking about DNC and
right.
DNEs. Probably gonna get out of that topic and start asking you other. You don't have any surgeries? Why didn't you put anything from residency?
I was in a unique situation. I was an attending for a year, so I didn't have like my case list from residency, and then I had to use an 18-month one for my OB, and I couldn't do it for both. So this is where we're at.
Wow, okay. Everything is a DNE, right?
Yeah, DNE or DNC. I got very creative.
I'm trying to be, you have a complication here. You have uterine
Yeah,
perforation.
yeah,
Okay. You want to tell me about this? They can ask you the first thing they're gonna look at your case list, they're gonna look at the side where the complications are and see if there's anything interesting to ask you about. You do have a
sure.
uterine hemorrhage, but that's OB. They probably won't
Yeah,
ask GYN, OB questions in GYN. So let's talk about case 80,
sure. You want me to tell you a little bit about her?
please.
Okay, so this is a patient that had a undesired pregnancy at 12 weeks and 0 days. She had her DNC performed by another provider and was discharged from the hospital. However, a couple hours later, she came in for acute pelvic pain. So I went to the emergency room. At that point, the ED providers had done a CT scan on her as their first imaging modality. And at that point, they saw a small volume hemoperitoneum and a 8 millimeter fundal uterine perforation. So we came to bedside to evaluate her as the operating team earlier on the day, that service. And we did a bedside ultrasound exam that confirmed that we saw a small volume hemoperitoneum as they saw in the CT. And we did a serial abdominal exams and serial laboratory evaluation to make sure she didn't have any worsening injuries.
Okay. So what would you have done if you had a uterine perforation that was bleeding?
Like in the operating room.
Yes.
Yeah, so I think the most important thing is when you identify that you have the perforation, whether that being clinical signs such as bleeding, or if this patient's not under anesthesia, acute pain during the procedure, or if you have like ultrasound findings such as your instruments going past the uterine serosa, or of course if you pull out anything that looks suspicious for bowel during your procedure. If she was acutely bleeding, I would try to see what the cause was. If I thought it was due to a uterine perforation, I would let my anesthesia team know. I would have them send stat labs. If she was hemorrhaging at that point, I would probably decide to proceed with a laparoscopy so I can evaluate for the site of the injury and repair as needed.
Right. And what if the bleeding was like from the inside of the uterus and not from the outside?
Yeah, so different things you can do to manage that would be like a uterine balloon, and that could help put some pressure on the area of the bleeding. Of course, if this was expanding like a hematoma into the broad ligament, then I would be needing to do a abdominal approach to be able to repair it.
Okay. Um, so that sounds good. It's a good answer. Other answers would be, and I think I went over this before, and I think this was in Pearls of Excellence when I looked at it. You can do electrocoagulations from the inside. You can inject vasopressin. You can do a Foley tamponade. You can do packing, any of that stuff. And then obviously, if that fails, you're going to have to go from above and do something surgically. But those are the things like if you had like something bleeding from the inside but didn't perforate all the way through, then this is something that you can consider doing.
Yeah.
Honestly, I'm looking through your case list and I don't know what to ask you with the DNEs. What
Even
are
if you
some
want to do like a structured would be fine. If like a version of a structured case off one of these would be
so a
helpful.
G1, so I can ask you questions about how do you pick who is a good candidate? What are some factors that help you decide what method of a hysterectomy you would do?
Sure. The first thing I try to do is ideally my preferred route of hysterectomy would be a vaginal hysterectomy. Candidates that would look eligible for that would be based on their uterine size, their mobility of their uterus, the indication for the hysterectomy in the first place. So somebody with benign disease, somebody that has just like abnormal uterine bleeding, adenomyosis. Those would be all indications that I would be comfortable doing a vaginal hysterectomy for. People that I would maybe consider doing a TLH on instead would be people that have like adnexal pathology that I would need to evaluate laparoscopically if I was going to try to do a concurrent procedure annexally. While you can't access the adnexa vaginally, it is a little bit more complicated to do so. People I would do an open hysterectomy would be somebody that has a concerning for a malignancy or somebody that has like
Yeah.
a bulky uterus that I wouldn't be able to deliver vaginally.
I'm cutting you off only because I didn't ask you about the hysterectomy part. Everything that you said is okay, but I just asked you about, I did ask you how you decide what mode of delivery, but you need to answer a little bit and then stop and wait for
Okay,
the next question and not just get carried away and talk more because that will take you into a rabbit hole and you're going to probably
sure.
talk about something that the examiner didn't want to talk about.
Okay,
So I did ask you, what was the first question I asked you? I asked you, how do you decide what mode of delivery, right?
sure.
How are you gonna deliver the uterus? Like, are you gonna
Oh,
or
I'm sorry. I thought you meant mode of how I decide what candidates for mode of hysterectomy, not the delivery of the uterus. I'm sorry. Yep.
correct? No, I think I confused you. It's my fault. Let's start over again. Who is a good candidate for a vaginal hysterectomy? That's a
Yeah,
that's a question they will ask, and a lot of people don't have a lot of vaginal hysterectomies on their case list. Some of them only have laparoscopy, and so they will ask this exam. How come you don't have vaginal hysterectomies?
right.
Who would be a good candidate for a vaginal hysterectomy? Who wouldn't be a good candidate for vaginal hysterectomy?
Yeah, so a good candidate would be a patient that is having a hysterectomy for a benign reason. Somebody that has a uterus that I feel like could deliver vaginally. Typically, cutoffs I had done in residency was usually 100 to 200 grams. Um, Somebody that I have like a mobile uterus that I feel that would have good descensus. And then somebody I would be able to just access visually. I can see like on my exam, like their cervix, and I can visually identify the cervix prior to the hysterectomy.
Okay. Um, so how do you position a patient in vaginal hysterectomy? What's the ideal position for her in the OR?
Yeah, so they're going to be in lithotomy with either like stirrups. Typically, people use candy canes as well.
Okay. So, what is the angle that you put the legs in a vaginal hysterectomy? Because that's different than a laparoscopic hysterectomy.
Sure. So typically you have a 90-degree angle of the knee and the lower leg, and then the hips are usually a little bit more hyperflex compared to in a TLH.
Okay. What are some contraindications for a vaginal hysterectomy?
Sure. So one would be somebody that is having this for a indication for a cancer, somebody that you are not able to visualize your cervix. So sometimes certain people, patients with obesity or history of nulliparity might make it more challenging to be able to see vaginally. Um,
They
those are
might
my
ask also to describe how a vaginal hysterectomy is
sure.
done so that you don't have it. Can you describe how it's done?
Yes, I still need to practice this part. So it's been a very long time. But the first thing I would do is obviously positioning the patient. I would then put in a Foley catheter. I would then place a weighted speculum and a Deaver retractor to be able to see my cervix. I would grasp my cervix with a tenaculum and then typically use lidocaine and vasopressin injecting into the cervical mucosa. I would then outline where I'm going to do my peripheral circumcision with either scalpel or with Bovie cautery at that time. Typically, approach it, was taught to do a posterior entry first, so grabbing the from where I made my circumscription, use a like Alice clamp to use METs to identify the entrance to the posterior cul-de-sac. At that point, you can take down the uterosacral ligaments to get better exposure and then reposition your weighted speculum into the peritoneum. And at that point, I would make an approach into my anterior entry as well, again, elevating with like an Alice and using METs to dissect the bladder off the cervical vesicle junction. I would then proceed with clamping and ligating my cardinal ligaments and my uterine artery. Um, and then I would deliver the uterus once all my pedicles are cut and have hemostasis. And then I would close the vaginal cuff with running suture.
Okay. Um, so what is a McCall and what is the benefit of doing it?
Yeah, so McCall is incorporating your uterosacral ligaments into your closure of the vaginal cuff, and that can help reduce prolapse after a hysterectomy.
Okay. Let's go a little bit about the questions that I asked you.
Sure.
I think you did good. So you decide on how you're gonna remove the uterus based on the degree of prolapse of the uterus, the size, the shape, the descensus. You look at the vagina, the vaginal length, the caliber, the infrapubic angle. You read the history, how many kids she has, how many vaginal deliveries, how many C-sections, whether she has PID before, pelvic surgery, endometriosis, because this patient might not be a good candidate for vaginal hysterectomy if she has any of those. So the person who would be a good candidate for a vaginal hysterectomy would be someone who has adequate vaginal access, good uterine descent, good mobility, small size uterus, and benign uterine disease. Without any like adnexal masses, you can still get the adnexa out if you're very experienced with
Mhm.
doing vaginal hysterectomies, but a lot of people prefer to do it laparoscopically once the patient has something on her ovaries so they can look around and see what's going on the inside. Patient who is not a good candidate will be somebody who the uterus is about like more than 280 grams, although this is a relative contraindications because there are people who actually deliver bigger uteri through the vagina after doing I keep saying deliver, but I mean like after you do a hysterectomy, you can deliver it out by bivalving the uterus and taking it out. So the weight is a relative contraindication. But if there is no vaginal space, if there is like less than 2 finger breadth at the apex of the vagina, if there's extrauterine pathology, if the infrapubic angle is narrow, then this patient is probably not the best candidate for doing a vaginal hysterectomy and is probably better off doing a laparoscopy. When I asked you what is the ideal patient position for vaginal surgery, so you are going to say that high lithotomy position is the
Mhm.
position for a vaginal hysterectomy versus a low lithotomy position for laparoscopy. So high lithotomy position, trunk thigh angle should be more than 60 degrees. You don't want to increase the knee flexion because that could lead to sciatic nerve injury. The hip abduction, which is the thigh to thigh angle, should be less than 90 degrees because if you stretch it more than that, then you can injure the obturator nerve. And then the vaginal hysterectomy, I'm going to say it again, just for
Yep.
whoever is listening. Put the patient in high lithotomy, high dorsal lithotomy position. You use the retractors. You grasp both anterior and posterior lips of the cervix with the tenaculum. You inject vasopressin beyond the mucosa above the cervical vaginal junction. You cut the vaginal wall above the cervix circumferentially at a depth superficial to the pubocervical fascia. Then you enter the anterior peritoneum. You elevate the anterior vaginal wall with an Alice, and traction reveals the cervical vesicle band. You push bluntly with gauze to push the bladder upwards, and then you grasp the vesicouterine fold. You make a small cut and enter the peritoneum. And I used to tag it.
Mhm.
I stitch and tag it so I know where it is. You do the same on the posterior peritoneum. And then after that, you identify the uterosacral and cardinal ligaments. You clamp them, cut them, and ligate them. And of course, the uterine artery and uteroovarian ligament with them. And then you remove the uterus and close the cuff. And in terms of closing the cuff, you're going to do the McCall, and the McCall is used to suspend the vaginal apex to prevent enterocele, and it also obliterates the cul-de-sac and supports the vaginal apex and lengthens the posterior vaginal wall. So that's the benefit of the McCall. The technique is that you take the uterosacral ligament, you tag both of them on both sides, and then you hold them, you place them under tension, and you start with the left distal uterosacral ligament, and then you go with your needle to the cul-de-sac or peritoneum over the rectum, and then to the right uterosacral, and then to the midline of the posterior vaginal wall, and then you pull it together in a purse string. So from one uterosacral through the peritoneum over the rectum to the other uterosacral through the posterior vaginal wall, and then you do the purse string, which results in fixation of the vaginal apex to the distal portion of the endopelvic fascia, and it prevents the enterocele.
Great. That was very helpful.
Yeah, if somebody doesn't have a lot of vaginal hysterectomy cases, they might ask you how you do it, just to see if you know.
Yeah, that sounds great.
Thank you so much. I need to take 6 people, so I'm gonna go take somebody else. So, thank you so much. Let me, can you mute yourself? Wait a minute. Joel, let me mute you. I'm muting you. Okay. Next on my list. Let's see who I have here. Sorry for this delay. This is a bit frustrating finding people who haven't been called often because everybody needs to be called who paid money for this at least twice. So I'm struggling to find the names. Okay, LaShawn, I'm gonna try you again. I'm muting LaShawn.
Hi, I'm so sorry.
No worries.
Been a night, so let me get my brain in the go.
Oh, wait, I have a ton of questions. What's going on here? Okay, that's you, part of it. Oh, somebody was saying you can ask her about molar pregnancies. I could have, but that's okay. Is it okay? Oh, somebody's asking me. Tawana asking me, is it okay to say we don't use vasopressin? Yes, it's okay. Okay, everybody does it a little bit differently. As long as you're doing the right thing, then it's okay. Okay. So are you okay if we talk a little bit more about vaginal hysterectomy?
Who, me?
Yes.
Sure. Sure.
Okay. Tell me, if you're doing a vaginal hysterectomy and you lose the pedicle, what do you
Mhm.
do?
If I do a vaginal hysterectomy and I lose a pedicle, I assess if there is any bleeding happening and I try to find back the pedicle. Um, that's what I would do.
You don't find the pedicle. It's lost. It's retracted inside the abdomen. What do you do?
If the pedicle is retracted and I am assessing my surgical field and I don't appreciate any bleeding or any hemorrhaging, I would continue the vaginal hysterectomy.
And then what?
Towards once I'm done completing the vaginal hysterectomy, I would then again evaluate my surgical site to assess if there's any signs of any bleeding. And if not, I would complete the hysterectomy. And I would also, excuse me, another thing that I would do would also ask the anesthesiologist any signs, assess her vital signs, any signs of like a hypovolemia or anything that I could be missing. But I would complete the hysterectomy and assume that it is hemostatic.
Okay. But you lost the pedicle and it might have like a vessel in it and it went and it retracted in the abdomen. Do you feel comfortable closing her, not knowing what happened to that pedicle?
Um, I would feel comfortable after I did a thorough examination to assess for any bleeding. In my opinion, by the time I completed that hysterectomy and I did several looks, if there was no bleeding, I would feel comfortable closing her and observing her.
So, did somebody tell you in a previous webinar that it's okay to do that? Did you hear a
Yes.
previous webinar that said that? Which doctor told you that? Do you
I don't
know?
know, but I remember being told that if it looks fine, if it's not bleeding, you can go.
So,
You
the
can keep
reason why
going.
I'm asking this is I had 2 private mock orals today that I did with candidates from Exampro, and we just did GYN today because they wanted to do GYN. And I just went over and I asked both of them the same question, and they both answered me the same answer that you're answering me now. And then I
Yeah.
said, And I said to the girls that I was talking to the other one that I was talking to, who told you that? And she said, somebody said it on Exam Pro. So while I was talking to her, I actually called Dr. Green and I asked him, and he thinks like me that if the pedicle, I don't know which doctor told you that, but to be on the safe side, you might have crushed it with your clamp and it
Uh-huh.
stopped bleeding and it retracted in there, but the
Mhm.
patient is sleeping and she's more likely under anesthesia and hypotensive. When she wakes up and starts moving around, that vessel might open and cause bleeding in the abdomen. So my advice in the oral board exams, not to say that. Do not say I will not go back and look for that pedicle. I think the best answer to say is I will if I can't get to the pedicle and there's no active bleeding, I will finish my surgery, but then I will go laparoscopically and I will go and look and see if there's anything I missed or look for that lost pedicle so I can suture it and ligate it because that pedicle that might not be bleeding now will probably bleed later on, and
Okay.
that people might have a branch of the uterine artery or something like that. So I don't know. I wouldn't risk it. And
Okay.
that's what I thought. But then when I confirmed with Dr. Green, he said the same thing. And
Okay.
so it's better always to be cautious, always be careful than, just letting it go. So that's my advice. If you get asked this question, say that you are going to go from above and look for the pedicle if you couldn't find it vaginally, if it's retracted and went inside somewhere.
Okay. Will do.
Okay. What GYN procedures need antibiotics?
GYN procedures that need antibiotics would be so clean contaminated procedures. So procedures such as hysterectomies, um, uh, procedures such as like anterior and posterior repairs, procedures where with mesh where you're placing a foreign body, um, procedures such as a DNC for like a missed abortion. Um, what else? Um, procedures where if you were doing an HSG and they had history of PID, you could give doxycycline as well for that. And those are the ones that are coming to mind at this time.
Okay. So hysterectomy, urogyne, salpingogram, saline histogram, and induced abortion. Do you
Yes,
do on your case list, do you have robotic surgeries?
I do.
Okay, so what are the advantages and disadvantages of doing robotics? And do you do all your cases robotically or do you do some laparoscopically and how do you pick them?
So I have both laparoscopic and robotics on my case list. I tend to do patients that I'm anticipating a higher level of adhesions on the robot. So patients
Charging
have history
battery.
of endometriosis or documented previous operative reports with extensive adhesions. Patients who may have like a larger ovarian mass, and I'm trying to preserve the ovary and perform a cystectomy. I tend to do that robotically as well. Patients who those are the my biggest candidates for robotic surgeries. In addition, if I practice somewhere where I do not always have a partner to assist me, and I may have a surgical assist. So it also depends on if I don't have an appropriate assist to do it laparoscopically. I'm able to have more ability to complete the surgery with a surgical assist on robotics safely for the patient. If I do not have the appropriate assist, I just can, um, what is the word that I'm looking for? But essentially, I have more control of my hands and can do more finer dissection on the robot if I do not have an appropriate assist. I would say that um, a more a drawback to the robot is that it is more costly. Um, I know that for some it may be more time consuming to dock. I do find, however though, that the total time of the surgery is not different for me with laparoscopic versus robotic, especially if I am doing it with a provider who is not as skilled. Um, but the biggest drawback I would say is the cost of the robot.
Okay, got it. And so I think there's a practice bulletin or a committee. I think there's a practice bulletin about this. It says that the advantages would be improved optics, including 3D view. There is enhanced surgeon dexterity. It permits minimal invasive surgery in more complex cases. Disadvantages is that it decreases haptic tactile sensation, so you can't really touch it with your hand. There is increase in operative time and increase in cost. But I mean, if you're really experienced with doing the robotics, there's probably not much increase in robotic time, right? Especially for just at the beginning of the case.
Yes.
I'm sorry. Okay. And so do you do anything laparoscopically or is it all robot?
So I tend to do like my cystectomies, most majority of my cystectomies over I do laparoscopically. I do laparoscopic salpingectomies, diagnostic laparoscopies. Some of my hysterectomies that I don't anticipate that may be smaller or I don't anticipate. Um, well, no, I don't have any of those in my case currently. But if I have a partner to assist me, then I would offer the laparoscopic procedure as well, as long as I have an appropriate assist to assist me.
Okay. Um, Let me go back here. I'm going back to the case list. But before that, I'm reading here. Nuria says there's a pearls of excellence about the lost pedicle, and it says to explore laparoscopically or to open. Yes, that's what I thought.
Okay.
Um,
Okay. Thank you.
just
I'm
for
glad because I
no,
was going to say leave the pedicle.
I know. No, so always err on the side of caution. If you're unsure, do the thing that makes you sure.
Okay.
I would feel very uncomfortable leaving a pedicle. I would feel like this patient's going to come back and it's going to be a disaster and she's going to be bleeding and, we're going to have to run to the OR and give her blood and stuff like that. And you never want to do that. Okay. Give me your differential diagnosis of vaginal bleeding or discharge after a hysterectomy.
So my differential diagnosis of vaginal bleeding and discharge. Okay, so it would be uterine dehiscence, a vesicle, a fistula of some sort, vesicovaginal or uterovaginal, or even rectovaginal fistula. It could be a vaginal cuff cellulitis, or it could be a vaginal vaginitis picture as well. It could also be a potential opening with a potential prolapse of abdominal structure, and leakage. Those would be my top differentials at this time.
Okay. So retained suture or any other foreign material that is not completely reabsorbed. Granulation tissue reaction at the site of the vaginal apex closure. Could be entrapment of intraperitoneal tissue at the vaginal apex closure, like fallopian tube or bowels. It
Mhm.
could be if the patient had sex, if she has traumatic bleeding from coitus or using a tampon, pushing it too far. It could be also a retained vaginal sponge or any other foreign body from the operation.
Okay.
Okay.
If
Um,
I don't give like all, because I feel like all that, yeah. If I don't give all of it, because I feel like my nerves may only have me stop at 5 or 6, would that be terrible if I didn't give all of them?
it would not be terrible. A lot of people won't remember all of them. So whatever you remember is good.
Okay.
You guys, you don't have to remember everything. Nobody remembers everything. Even the examiner who's asking you doesn't remember everything. Whatever you can remember is good, as long as you don't stay blank and not say anything.
Okay.
You might say some things that are not the things that I said, but they still apply and they're still okay,
Okay.
right?
Okay. Yes, ma'am.
And then just say it again to everybody. And I say that to everybody when I do mock orals with them. If you don't know, don't make things up. Just say, I will have to look that up. What that does is that saves you the embarrassment of looking at them and not knowing. If you say something wrong, that could take you down a rabbit hole and they can start asking you more questions about something that you're not very well read on. And then it just, it buys you time because then you're like, I will have to look that up. That means they're going to move on to the next question. They're not going to keep asking you about stuff that you don't remember. And then if there's something that you do know, but you're so flustered you can't remember it, you can say, can we get back to this later on? I mean, I know this. It's not coming to me right now. And then they'll move on to the next topic, and they probably never will come back to that topic because time goes really fast in the oral board exam, and there's a lot of things they can cover and ask about. So it's okay if that happens. It's okay if you don't remember something, or if you forget something, or you don't know something. A lot of people get flustered and upset if they don't know one thing, or they say one thing complete, or the examiner gives them a hard time about one thing they talked about but shouldn't, because the exam, half of it is case of the day and half of it is structured case list. Even if you completely did bad on
Mhm.
your case list or on the structured case list, but you did really good on the upper part, you passed. And
Mhm.
even if you completely failed one station, like let's say, God forbid, any one of you fails like GYN or office, but you did really good on the other two, you still pass the exam. So there's a lot of room for you, to feel comfortable. Don't feel so stressed. I know it's easier said than done, but keep telling yourself it's okay if I don't know a couple things. Don't let your head like get like jammed and don't know how to answer some questions, because I've seen people that were with me actually in the oral board exam who were really smart, great doctors, who like they got asked one question and they didn't know it, and it kind of ruined the rest of the exam for them. So don't
Mhm.
let that happen to you.
Okay, thank you.
What are some risk factors for post-op wound infection or
Um,
doing plan?
I'm so sorry. For post-op wound infection,
Yes, and like after a C-section or a hysterectomy or whatever, any
so
surgery.
yes, larger BMI, obesity, poorly controlled diabetes, um, not keeping the area clean and dry, um, prolonged operation time, hemorrhage, excessive blood loss, poorly controlled hypertension. Um, what else? Um, and a co-infection with like a bacterial vaginosis or a vaginal infection, um, or underlying STI all increase the risk of vaginal STI, increase the risk of wound infections.
Okay, so type 1 or type 2 diabetes, especially if it's not well controlled, if she's using steroids, smoking, poor hygiene, poor surgical technique, and obesity are some of the risk factors for wound infection. Another way that question could be asked, the one that I just asked you about vaginal bleeding or discharge post hysterectomy, they can also ask the same question in a different way. They can say differential diagnosis of vaginal mass, vaginal apical mass after a vaginal hysterectomy. Same thing. Could be an abscess, it could be hematoma, it could be entrapment of bowel, it could be a lot of things. And so they could be answered the same way.
Okay,
Okay, I'm gonna let you go and I'm gonna call somebody else.
thank you.
Thank you so much. Okay, Sean, muting you. Okay. Um, Laura McDowell.
Hello.
Hi, Laura.
Hi.
How are you?
I'm doing well. How about yourself?
Great, with my two cats who are sitting next to me.
That sounds very lovely.
Okay. Um, I want to do a little bit more GYN today. Is that okay?
That sounds great.
Okay, we're talking about wound infection. What is the most common organism in wound infection in GYN, and how do you treat it? What are the antibiotics that you would give for wound infections?
Hmm. So I would say the most likely wound infection would be a Staph aureus. So typically could be treated with an amoxicillin or a Keflex, a gram-positive antibiotic.
What if she's allergic to Keflex? Then what would you give her?
I would want to, if she's allergic to Keflex, then I typically would, one, want to assess the degree of her severity to uh, of the allergy or reaction. I then would likely change to like clindamycin or gentamicin together. Uh, for surgical prophylaxis.
Okay. And so the antibiotics could be like Zosyn, could be Unison. Um, you can give Keflex. If the patient is allergic, you can do Clenda or erythromycin. Or if you think there's MRSA or there's an abscess, then you can do like Vanco or Flagyl. Depending on what you do, you're going to culture the wound and see and go from.
Yes.
Um, so when you do cases, what do you have on your case list on your GYN? You have uh, laparoscopy? Do you have total abdominal hysterectomy? What do you have?
So I have total vaginal hysterectomies, laparoscopic hysterectomies, laparoscopic sterilizations.
Okay.
Um,
Can
Unfortunately,
you
no TH.
okay? Can you dictate a total abdominal hysterectomy? Can you tell me how
Hmm.
it's
Yes.
done?
So
Okay.
I would start with doing a vertical midline incision and go down through the layers to the fascia. I would uh, elevate the fascia and make my incision with cold scissors and then extend that. I would elevate the fascia with Coker's and then enter into the peritoneal cavity and extend that further. Um, Typically, then I would place the Bookwalter retractor and then end up packing the sidewalls and again, then pack the bowel cephalad away from the operative field. Um, I suppose actually before packing, I would want to do an exploration of the uterine cavity and then would pack the bowel. Then I would place two clamps on the uterine cornua to elevate the uterus out of the pelvis. And then I would enter the retroperitoneum by elevating the round ligament and making, using electrocautery, going parallel to the IP ligament to enter the retroperitoneal space. I then would dissect down to find my ureters and make sure that I know where those are in relation to my uterus. Then, depending on whether I was doing a bilateral salpingectomy or a bilateral salpingo-oophorectomy, I would then isolate those structures, taking them down with electrocautery and doing that through the round ligaments down through the anterior broad and the posterior broad ligaments as well. Once I got to isolating and dissecting down the vesicoperitoneum from the lower aspect of the uterus, I then would work to isolate my uterine arteries, and I would clamp these, cut and place suture in a transfixion stitch. I then would sequentially go down on the cardinal ligaments and do a clamp cut tie procedure with transfixion stitch until I got to the level below the cervix, which I would be assessing with palpation. I would be doing these steps on bilateral sides, alternating between the two. And then once I felt that I was underneath the cervix, I would place a clamp across the tissue and cut this to remove this specimen from the field. And then I would place sutures along the vaginal cuff to close this to ensure hemostasis.
Thank you. Thank you so much. Was that difficult? You haven't done it in a while?
You know, it's been over a year since I did a TAH. So yes, that was difficult.
I can tell you're trying to visualize your step as you're saying it. Okay.
Definitely.
So you do an abdominal incision, either vertical or transverse, depending on what surgery you're doing and what's going on in there. And then, like you said, you put the bookwalter, you pack the bowels, and then you get to the uterus, you grasp the uterus, you elevate it, and then you go to the round ligament, you transect it to provide entry to the retroperitoneum to identify the ureter. And then you go to the anterior leaf of the broad ligament, you open that, you identify the ureter on the medial leaf of the broad ligament. You open the posterior leaf of the broad ligament. If the ovaries are conserved, you're going to clamp the fallopian tube and the uteroovarian ligament. If the ovaries are removed, you're going to clamp on the IP ligament. And then you're going to cut, ligate the uterine arteries going down, and then the cardinal uterosacral ligament. And then you close the cuff. That's just briefly with a little bit less detail than what you did.
Okay.
Do you
Is
want
that
to?
kind of what they're generally looking for? Just a little more cut and dry like that?
You don't have like 10 minutes to go over this. This is a short question.
Totally.
One of many questions they're going to ask you to say that you passed the exam. So they're not going to stay, like when we do the webinars and like we talk about osteoporosis for 15 minutes or 20 minutes, they're going to do that in
Right.
5 minutes. Well, the reason why we do that in the webinars because we want to try to ask all the questions that could be asked. But in the exam, you're probably going to be asked one or two of those.
Mm-hmm.
So you don't have to be so much detailed. You can just say it briefly.
Okay, perfect. Thank you.
Okay, let's do something else with you. Can you dictate an LAVH?
Yes. So for an LAVH, I would make my trocar placements typically with one in the umbilicus and then two off to the right and left lower quadrants, roughly 2 finger breaths superior and medial to the ASIS. I then would typically be doing a bilateral self-pingectomy, so would identify the fallopian tubes and where the ureters are in relation. Typically, I would see those vermiculating.
Mic off.
And then I would use electrocautery to sequentially coagulate the tubes to the cornua. I then elevate and grasp the round ligament, sequentially fulgurate these areas, cut, and then carry down to the anterior broad ligament and then also the posterior broad ligament down to the level of the internal cervical os. I then work to dissect the uterine peritoneum from the cuff site, the colpotomy, and then I sequentially coagulate and transect my uterine vessels and then carry lateralize down the cardinal ligament until I am past where my colpotomy would be created. Then typically what I have done in the past for LAVH is I do use a monopolar spatula to create an anterior entry point and a posterior entry point along the cuff. And then my attention is turned vaginally, where I go down, take out the uterine manipulator, and then place a weighted speculum in the vagina with a dever on the anterior vaginal mucosa, and then use clamps to grasp my uterosacral ligaments and complete the colpotomy vaginally with clamp cut tie. I then grasp the cervix as well. I guess I would have grasped the cervix before doing the uterosacral bites with a single tooth canaculum to deliver the uterine specimen through the vagina. And then I would close the vaginal cuff with vaginal running suture with care to incorporate the uterosacral ligaments in my cuff closure.
Okay. Let me say it again after you. But I'm going to say it a little bit differently. Everything is That's good. I use the Allen stirrups to position the patient in low lithotomy position, tuck the arms, place the Foley, uterine manipulator inserted. I use a 10 millimeter Hassan trocar subumbilical and then the other two ancillary incisions. I survey the abdomen to rule out malignancy. And if I'm removing both, if I'm doing a BSO, I'm going to elevate the ovaries and open the posterior peritoneum lateral to the IP ligament, clamp, cut, and ligate, cut the broad ligament, open the peritoneum at the vesico-uterine junction, move the bladder away from the lower uterine segment, clamp, ligate, and cut the uterine arteries, and then the uterosacral and cardinal ligaments, and then deliver from below and close the cuff, release CO2, and monitor the pedicles. And if there's no bleeding and everything is okay, then I would close the incisions. You said it in more detail. I just said it briefly.
Okay.
Somebody asking me, again, I think Irene here wrote me a question. Can I repeat the differential diagnosis of vaginal bleeding after a hysterectomy? Okay, I'm gonna do it real fast because I want to take more people on the hot seat. So either you have a retained suture or foreign material that is not completely reabsorbed, or granulation tissue reaction at the site of vaginal apex closure, or entrapment of intraperitoneal tissue at the vaginal apex closure, like fallopian tube or bowels, or it could be traumatic bleeding from intercourse or using a tampon, or it could be like a vaginal sponge or other foreign body from the operation. I think I have another question. When should we stop and say we would go below in our LAVH? I had a mentor tell me that once doing bladder flap, that could be seen as more of a TLH and challenged when it became an LAH. I don't understand the question. Did you understand her question?
So I think it's basically asking where does the laparoscopic portion of the LAVH stop? I know I've heard some people when they for an LAVH that it's if you take your cardinals and your uterines vaginally, then that would be considered a LAVH. But to the exact technicality of that, I can't speak.
So laparoscopic assisted vaginal hysterectomy is when you do some of it from below and then you go from above and finish it. Total laparoscopic is that you do none of it from below. You just put the manipulator and you do everything from above. That's the difference, right?
Right.
So I don't know if Tawana, if that answers your question. Okay, I have more questions. Dina, if you only do TVH, TLH, robotic, and open, is it okay to say you don't do LAVH? Yes, it's okay to say that. They might ask you why. You can tell them that's what you're trained to do. Can we walk through the removal of an enlarged specimen? Okay, does that mean like the enlarged uterus? So I believe you hold the uterus with the tenaculum after you separate the pedicles. And then you bivalve it, like you cut it from the cervix up until the uterus and you bivalve it. I don't know if I'm explaining it correctly. Do you understand what I'm saying? Who am I talking to?
Laura.
Laura.
Yeah, I do. Yeah, where essentially you're taking the cervix down through the vagina and then you're making incisions to kind of take out the bulk in the inside of the uterus.
I've seen two attendings do it in different ways when they trained me in residency. Some of them cored out and took punches from it to make the diameters less. And that way it kind of decreased in size and then he pulled it out. And others just completely used like a big scissor or like a knife and cut it all the way in half through. And then they bivalved it that way and pulled it out. So I think everybody does it differently.
And then there's also the excite technique that you can do to take it out abdominally if you don't think that it will fit out vaginally.
Okay. A lot of people are writing me a lot of things. Okay. Yes, that's what I meant, Tawana. Okay. Bivalve it, leaving the edges intact so there is no bleeding literally when you extract it vaginally. Yes. Can we say coring inside the specimen? Yes, that's what I was just saying. Yes, you can core. Like I just said, I've learned it two different ways. You can core it or you can bivalve it, either way. Okay, I need to take 6 people because an example, they've been asking me to do 6 people and I'm having it hard when I'm explaining and talking to do the 6 people. Last time I did only 5, I think. Thank you so much, Laura, for
Thank you.
that seat, and I'm gonna take somebody else.
Thank
Okay. How about I take Bernice? Bernice, you're on my list, but I don't have you raising your hands. Do you want to be on
Hi.
the?
Yeah, that's all right. I didn't raise my hand because I'm on call, but right now I think I'm okay.
It's okay. Let's talk even for 5 minutes, and then if you get called, just say I got cold, and I'll call somebody else.
Okay, sounds good.
Okay. Can we do a little bit more GYN? Are you good with that? Or
Sure.
do you want to do something else?
No, that's fine.
Okay. Let's do common places of injury of the ureter when you're doing laparoscopic surgery.
Okay. At the pelvic rim, there's also whenever if you're getting the IP ligament, as well when you are in the cardinal ligaments, and as when you are doing the colpotomy as well.
Right. So while ligating the uterine artery under the cardinal ligament, while ligating the uterosacral ligament near the uterosacral ligament within the broad ligament, while ligating the IP at the lateral pelvic sidewall, and while closing the vaginal cuff upon insertion into the bladder. What are some risk factors for puncture injuries and laparoscopy?
For puncture injuries of the bowel,
Risk factors for puncture injury of anything in the abdomen.
okay. So definitely a patient that has had multiple surgeries, somebody that has multiple abdominal surgeries, somebody that has endometriosis, somebody that has had a history of an infection like PID or TOA. It depends on the entry. So if the patient has, once we know that a patient has risks, if we don't do things that could prevent a puncture, like if the patient had a history of a gastric bypass, then we should avoid Palmer's point. If somebody had multiple abdominal surgeries, then that's when we could do Palmer's point instead of umbilical entry.
Okay.
A large uterus or specimen could also lead to complications.
So intra-abdominal adhesions, if there's insufficient gastric emptying and like the gastric is big, the gastric area is big, it could get injured. Insufficient pneumoperitoneum, those are some risk factors. Full bladder, poor muscle relaxation, the very thin patients and you push too hard and you go in deep. Inappropriate angle or force of the trocar insertion. So let's say, God forbid, you're doing this surgery, you go in and you injure one of those organs. What is the most common organ that is injured?
The most common injured organ would be the bladder.
Okay.
It depends on the surgery. During the hysterectomy, it would be the most common organ would be the bladder.
Well, you're going with the subumbilical trocar. The bladder is not too close. What is the most common thing you might go into while you're putting the trocar in?
Sorry. Yeah, with so the most common would be the intestine, the small bowel.
The small bowel, it is the most common, followed by right iliac artery, colon, iliac vein, and then aorta, IVC, abdominal wall vessels, and bladder is the least common of them all. The most common is the bowel. What are some preventive measures that you can do to help avoid bowel injury and laparoscopy?
So you can. So ideally, you have to do an orogastric tube, and make sure that the patient is level, that she's not in Trendelenburg or any other abnormal position. Then there really is no better entry like open entry or varus or direct visualization have the same risk. And then depending, as I said before, depending on what kind of like surgical history the patient has, trying to choose where to enter. So if she has a history of gastric surgery, then we'll go umbilically on the umbilical entry. If she has a history of multiple surgeries, then I would prefer Palmer's point.
Okay, so either open technique Hassan or Palmer's point or optical access trocar. Those are some of the ways that you can prevent injury. What are some contraindications to doing laparoscopy?
One of the contraindications is a patient that is hemodynamically unstable, that will not tolerate pneumoperitoneum. That's the main contraindication, I would say. Trying to think if there's any.
How much is the initial intra-abdominal pressure you put in? What is the level you do not exceed for the pneumoperitoneum?
Okay. I usually not more than 20.
Right. Okay. So contraindications for laparoscopy would be when the pneumoperitoneum is contraindicated, and that is, like you said, with patients with increased intracranial pressure, patients with glaucoma, or patients with peritoneal shunts. Those are the patients where you do not want to create the pneumoperitoneum because it can increase the pressure on those patients and affect their conditions. The initial intra-abdominal pressure is like less than 10 to know that you have correct placement of the trocar, and then the maximum is 20, just like you said. Okay, what is the ideal position of a patient in laparoscopy? How do you position those patients in terms of what kind of lithotomy, what angles are, how do you put the patient so you don't stretch the nerves?
So I would start putting, it depends on the kind of surgery, but some patients might need lithotomy at first, and then we can just lower the legs at 90 degrees. But the knee is kind of like at the same level as the abdomen. The patient should be leveled, level the table.
You got cut off for a second. Okay, so patients in laparoscopy should be put in low lithotomy position. The trunk to thigh angle should be around 170 degrees. The thighs should be at the level of the abdomen. If the thighs are below the level of the abdomen, more than 180 degrees, then that will strain the obturator nerve. The angle of the hip abduction, the thigh to thigh angle should be less than 90 degrees. If it's more than 90, that will also injure the obturator nerve. Okay, so to avoid nerve stretch, the thigh flexion should be less than 90 degrees and the hip abduction should be less than 45.
Okay.
What is the correct placement of trocars in laparoscopy? How do you place the trocars?
In my practice, I place a trocar usually starting in the umbilical, an umbilical entry, 2 bilateral ones in the lower quadrants, in the right and left quadrant, and then sometimes I do place a suprapubic port whenever I do TLHs.
Okay, so how do you do it? What's the angle when you're doing the subumbilical trocar?
So it depends on the patient. So if the patient is obese, you can go 90 degrees perpendicular to the abdomen. If the patient's thinner or thin and I'm concerned it could injure the vessels, the aorta or the large vessels, I usually would go less than 90 degrees.
What about the secondary trocars?
Same with the secondary trocars. I try to go first. I identify where I'm gonna go. Usually, I choose from the iliac crest, 3 centimeters medial to that, 3 centimeters on top of that, and I go perpendicular to the patient's abdomen.
Okay, so how do you do it so you avoid injury of the superficial epigastric artery and the inferior epigastric artery?
So we can transluminate, and so that way we can see the superficial vessels. and avoid obviously those vessels and rami of these vessels, and then anatomically trying to stay away from the mid, from at least 3 centimeters away from the midline. That's when usually we'll find the epigastric vessel. So if we stay lateral to that, we have less chance of injuring them.
Okay. So subumbilical 45 degrees in thin people and 90 degrees in obese. The secondary trocars, you want to avoid superficial epigastric artery by transillumination of the anterior abdominal wall. Avoid the inferior epigastric artery by inserting the trocar in the lateral third of the distance between the midline and the anterior superior iliac spine, superior to the anterior superior iliac spine, more than 6 centimeters from the abdominal line, because the inferior epigastric artery is at the anterior superior iliac spine. So you want to go superior to it, more than 6 centimeters from the abdominal midline. The epigastric, the inferior epigastric artery is around 3.7 centimeters from the midline and 2 centimeters above the symphysis pubis. So you just want to avoid where the inferior epigastric is so you don't injure it. When do you avoid the subumbilical entry in laparoscopy?
When somebody has had multiple abdominal surgeries, and especially if they have an open midline, they had a history of an open vertical midline incision, or more than 2 C-sections, you can think of avoiding it.
So if she has prior intra-abdominal surgery, if she has endometriosis, if you think the bowel is stuck, you're gonna avoid the subumbilical entry. If she has a prior ventral hernia repair, you wanna avoid going through the umbilicus. Or if she's pregnant, or if she has a large abdominal mass, you don't wanna poke through it, so you wanna avoid it. Bernice, thank you so much. I'm going to take somebody else.
Yeah.
Thank you for participating. Did I say your name correctly?
Yeah, that's correct. Thanks.
Okay, thank you. Okay, let me mute Bernice. And I have Genevieve. Genevieve, are you available? Genevieve? Hello? Okay, she's not available. Let's go somebody else. Let's do, sorry, it's taking me a minute to look at this list. Chikara Foster. Chikara? Hello? Chikara? Okay, not available. Let me see.
I'm available.
You are? Okay.
It just took a second to find the unmute button. I was like, I've been waiting for weeks. Please don't. Okay, I'm ready.
Sorry, I'm just trying to get as many people in as I can. This hot seat thing is getting a bit stressful for me because I feel like I have to get 6 people, and sometimes I call on people and they don't answer, and it's a long list, and I have a paper in my hand and I'm comparing names. It's a lot. Okay, sure. Let's talk about Palmer's Point. Where is that?
Okay, so Palmer's Point is 2 centimeters below the costal rim in the mid clavicular line.
Okay. 3 centimeters below the left costal margin in the mid-clavicular line. You are correct. What are the layers that you go through when you do the Palmers?
You go through the skin, the subcutaneous tissue, your fascia, your peritoneum.
So subcu fat, outer fascia, muscle layer, inner fascia, and then peritoneum. What about subumbilical? What layers do you go to when you do the subumbilical entry?
You go through the skin, the subcutaneous tissue, the fascia, muscles, the same, I would say the same. So the and then just straight into the peritoneum. I don't think there's any other fascia.
So
after.
so skin, subcu fat, rectus fascia, peritoneal fat, and peritoneum. While the palmars, you go through subcu fat, outer facial layer, muscle, inner facial layer, and then the peritoneum.
Okay.
And we go over the anatomy of the ureter. We've done it so many times, but it's so important. So I'm just going to have you say it again, please.
Okay, so it goes, I'm so sorry, I have a 2-year-old. It goes over the psoas muscle. It enters the pelvis at the bifurcation of the common iliac. It crosses medial to the IP. It then enters into the posterior broad ligament. It then crosses underneath the uterine artery and then medial and anterior to the cardinals and dives into the into the bladder.
Into the lateral aspect of the trigon. So the abdominal ureter is 15 centimeters and the pelvic ureter is 15 centimeters as well. The abdominal ureter commences at the renal pelvis, descends over the psoas muscle from lateral to medial, enters the pelvic brim at the bifurcation of the common iliac, and then we get the pelvic ureter. That's also 15 centimeters. It descends the pelvic sidewall posterior to the ovarian fossa, crosses under the cardinal ligament, crosses under the uterine artery, 1 to 2 centimeters from the cervix, continues anteromedially to insert into the bladder, the lateral aspect of the trigon.
Sure. Okay.
Okay. While I'm talking, if you're not talking, you can mute.
Can I mute it? Okay.
Bladder.
Yeah, how to mute it. Okay.
But for now, I'm going to ask you another question. Stomach injury during laparoscopy is not very common. It's actually 1 in 3,000. But what are some risk factors for stomach injury? How do you prevent it, and how is it repaired?
It may be injured if you don't put in like a nasogastric tube or some type of decompression to injure it. It may be injured if she just has a regular anatomy, or if she's had like prior surgery, such as like a Rowan Y procedure. Repair, I'm not familiar with repair at all, but I would suspect that if there was some type of injury, for sure, I would definitely call general surgery or trauma. But I would suspect they would put in some type of gastric tube to make sure that the stomach is decompressed and close it in layers. The muscular layers layer being like probably a running absorbable and using an absorbable stitch, and then the second layer being an imbricating, again using an absorbable stitch. But I'm not familiar with that at all.
So like I said, stomach injury is not very common. Risk factors would be prior abdominal surgery, difficult induction of anesthesia, and also like if it was like a fall or like inflated before the surgery. And so prevention, you would put a nasogastric or an OG tube prior to surgery. That would prevent it. Repair depends on how you injured it. If it was a varus needle, you irrigate. As long as there's no bleeding, you're good. If it's a trocar injury that requires repair, then you repair 2 layers with delayed absorbable suture. You always have to say that you're not going to do this because you're not trained to do this, but you know the theory behind it, unless you actually would do this, which I think none of us would. And then you would do a lot of irrigation after the repair and leave the NG tube in until the bowel functions return. Okay, I can see you muted yourself.
I'm hearing you. I'm just keeping it muted.
No, that's fine. I'm going to take somebody else. Is that okay? Because I need to take one more person.
Yes, that's fine.
Okay, thank you. Let's see. Okay, Tiffany Equago. Tiffany, are you there?
Hello, yes, I'm here.
Are you available? Okay, cool. So, what do you want to talk about?
Anything?
Would you like to talk a little bit about nerve injuries? Has anybody done nerve injuries? I think they did that in the webinars, right? They did nerve injuries and surgery.
I'm unsure if we have. We can. That's not my strongest point, so it'd be good for me to review it again.
Okay, let's do that. So, what nerve would be injured when you're doing a phalansteal incision?
So you could not nerve. You could injure your ilioinguinal nerve or your iliohypogastric nerve during making your incision.
What nerve would you injure if you're using a self-retaining retractor?
You could injure your femoral nerve.
What nerve could you injure if you have exaggerated flexion of the thigh?
Exaggerated flexion of the thigh. Flexion. Could that be your obturator nerve?
So cutaneous femoral nerve would cause injury, would cause exaggerated flexion of the thigh would be caused by cutaneous nerve injury, cutaneous femoral nerve. So ilioinguinal, iliohypogastric, T12 to L1 are usually injured in phalansteal incision. Genitofemoral nerve, L1, sometimes it's injured when you're using a self-retaining retractor. Lateral femoral nerve supplies the anterolateral part of the thigh. And the cutaneous femoral nerve, which is L2, L4, is the one that could be caused by exaggerated flexion of the thigh. And that one, what happens with that one when it's injured?
So that'd be a sensory loss that you would have on the lateral aspect of your thigh.
Right. And if you have injury of the femoral nerve, which could be caused by either self-retaining retractor or exaggerated hip flexion or external rotation, what sensory loss would you have, and what motor loss would you have?
So I believe motor loss, you would be unable to, is it like medially rotate your thigh, I believe. Like you wouldn't be able to, I think, get on a horse. I don't know if that's correct, if I'm making that up. And then
Can't get on a horse is the obturator.
oh, that's operator. Okay. So then I would have to look it up. I can't remember exactly. I don't know. I think I'll be making it up.
Okay. Let me tell you a little bit about a femoral nerve injury because it's very important. It is the most common neuropathy with pelvic surgery.
Okay.
And so lateral femoral is L2 to 3, cutaneous femoral is L2 to 4. So L2 to L4, the most common site of injury would be on the anterior surface of the psoas or the inguinal canal. As it passes beneath the psoas muscle, emerging as its lateral border, crosses the iliacus muscle, and then passes through the inguinal canal down the anterior thigh. And so the most common sites of injury would be either the anterior surface of the psoas or the inguinal canal. Injury would be from direct compression of the psoas muscle from the blades of the self-retaining retractor, or indirect stretch injury as the nerve passes through the inguinal canal. It usually happens in patients with thin body habitus, long retractors, prolonged operative time, hyperflexion and external rotation of the hip in the dorsal lithotomy position. Also in patients who have like decreased vascularization, like patients with diabetes, alcoholism, malnutrition, gout. Those patients don't have good vascularization. They're more likely to have those injuries. And so the nerve is less likely to withstand the insult. And so symptoms usually appear within the first 72 hours. Sensory symptoms would be numbness and paresthesia over the anterior thigh that extend down anterior medial aspect of the leg and the foot. And then for the motor, you'll have a weak patellar reflex, and there's quadriceps weakness as well. So you cannot straighten the leg at the knee. What do you do? How do you diagnose? How do you treat this?
Um, I feel like diagnosis would probably be from symptomology from the patient, kind of telling us that these things are happening. And then in terms of treatment, I would say physical therapy and time. And maybe you could also use, if there's any kind of pain, you could maybe use like a gabapentin medication.
Right. So you confirm the diagnosis by nerve conduction study. If you want like a confirmed diagnosis of exactly which nerves are injured. Physical therapy, non-steroidal anti-inflammatory, anticonvulsants like gabapentin or carbamazepine, and sometimes using a knee brace. How do you prevent this could be like a structured case question or even a question on the exam. How do you prevent femoral nerve injury?
You can prevent femoral nerve injury from one, ensuring that the patient is positioned correctly with not too much flexion. And then you can also ensure that when you're placing your retractors, that it's, if it's like a prolonged time, that you're kind of adjusting them so it's not constantly squeezing the muscle. That's what I would say.
Yeah. So good surgical technique, ensure lateral blades of the retaining retractor are elevated off the psoas muscle. You place towels between the retractor and the anterior abdominal wall so there's no direct pressure, like the towels are kind of padding it. You examine hip and dorsal lithotomy position to make sure the hips are not hyperflexed or overly externally rotated. And so that's how you prevent it. What about talking about peroneal nerve injury? How does that happen?
Peroneal nerve injury could occur if there's hyperextension of the between like the leg and the thigh.
Right, it occurs with stirrups in the dorsal lithotomy position when there's pressure on the lateral edge of the fibular head and it causes foot drop. That's the one that causes foot drop. And you prevent it by doing good surgical technique and positioning the patient on the table. Let me ask you nerve injuries related to patient positioning in the OR. So we just talked of the perineal nerve. The perineal nerve is usually injured at the lateral fibular head if the leg is rest on the stirrups. What about sciatic nerve? How is that injured? Where is it usually? What causes the sciatic nerve to stretch and get injured?
I would think if maybe you're using like the candy cane stirrups, or you have like extensive flexion between your hips, I guess. Like if your legs are in a very high position.
So the stretch is usually at the sciatic notch with hyperflexion of the hip.
Mm-hmm.
What about a tibial nerve injury?
Tibial nerve would occur if you don't have correct padding in your stirrups.
Okay. It's usually in the popliteal fossa with hyperflexion of the knee. If you hyperflex the knee, it causes tibial nerve stress and injury. What about femoral nerve? We just talked about that.
Yeah, that's with excessive flexion of the thigh.
Right. It's usually injured at the inguinal ligament or the psoas muscle with hyperflexion of the hip. What about brachial plexus? How is that injured?
In an infant, it could occur during shoulder dystocia maneuvers.
The OR.
So, but that could occur if you're having like you're doing an abdominal hysterectomy and the hands are extended, and then you're kind of sliding down the bed. So you
Right.
have
They can be stretched with exaggerated flexion of the head laterally or arm abduction more than 90 degrees. It could cause stretch on the brachial plexus. What about ulnar nerve?
I think that can occur when you're tucking the arms and I don't know, incorrect padding, extension of or rotation, I guess, of the hand incorrectly when you're tucking them.
Right. So the ulnar nerve is usually injured at the medial epicondyle and the arms are tucked in at the patient's bedside. Okay. I'm thinking what else to ask. What did I want to say? Where's your case list? Let's see, let's pull it up. This is your case list, right?
Yes.
Do you want to do more GYN or do you want to do OB or office? We have like 10 more minutes, 8 minutes.
You can choose dealer's choice. Anything's good.
Have you gone over your office case list?
No.
You haven't gone over it with anybody?
Oh, I mean, yes, but not here. I haven't gone already.
Is there any case that you're worried about?
um, Nothing really followed it. And there was stuff about like chronic pelvic pain is it's like a long one. I think we went over actually here the lichen sclerosis one that I had on there.
Oh yeah, this is the second time I call on you, right?
Hmm?
Okay. 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 I'm at a loss and I don't want to waste time.
Yeah.
You don't care anything?
Yeah.
Okay. Did you go over annual exam on those webinars?
I'm unsure. I don't recall if we have or not.
Okay, with whatever time we have left, which is not a lot, I would have started a new topic, but we don't have a lot of time. So let's just do annual exam because that's so important. I'll give you different age groups and you tell me what immunizations you would recommend for each age group. Just immunizations, okay? Okay, 13 to 18.
So 13 to 18, I would ensure they have their flu shot, that they have their HPV vaccination, that they have their Tdap, or that they have, I guess, I don't know what else. That's all I can think. I just like their meningitis if they're going to college. Those are the things that I could think of. Like hepatitis vaccines are up to date as well.
19 to 39.
Again, we could talk about Gardasil, flu, if they happen to be pregnant, Tdap.
Okay. Anything else?
That's all I can think of.
Okay, 40 to 64.
In this age group, I would once again flu, their this one that you get it's the Prevnar. I can't remember the name of the thing I'm trying to think of.
Okay, what about above age 65?
COVID, flu, and that's all I can think of.
Okay, let me go over them with you guys.
Yeah.
So annual visit, age 13 to 18. So immunizations would be influenza, Tdap, DT, MMR, and varicella, and COVID. And I would recommend those vaccines to all age groups. And the reason why I would recommend the MMR and the varicella and the Tdap to all age groups is because if those women are grandmas, nannies, caregivers, aunts, and they're taking care of newborns, then they probably need to be vaccinated. So I recommend them to everybody. In addition to that, in that age group, hepatitis B, HPV, and meningococcal vaccine. And then age 19 to 39, immunizations again, those 6 immunizations: COVID, influenza, Tdap, DT, the booster, MMR, and varicella, plus HPV vaccine. And then age 40 to 64, Again, COVID, influenza, Tdap, DT, MMR, varicella. You still do the HPV vaccine because it's up to age 45, but then you're gonna do the herpes vaccine, the zoster vaccine at age 50. And then above age 65, same COVID, influenza, Tdap, DT, MMR, varicella. No more HPV vaccine in this age, but you still do the zoster, and then you add the pneumococcal vaccine. What is the most common cause of death in ages 13 to 18?
Accident.
Correct. What is the most common age of death in women aged 19 to 39?
Same. Accident.
Cancer. What is the most common cause of death of women aged 40 to 64?
Cancer.
Cancer. What is the most common cause of death above age 65?
Cancer. Or is it-
Heart disease.
Heart disease.
Yes, like cardiac disease. Okay, let me ask you this question. Still have a little bit of time left. At what age do you order lipid, blood sugar, and TSH for your annual exam?
35 years old.
How often would you order the lipid and the sugar?
Every 3 years.
So every 3 years for the sugar at age 35, every 5 years
Lipid.
for the lipid starting at age 35. The thyroid, the task force says you don't need to do the thyroid, but the American Thyroid Academy, I think, says to screen every woman at age 35 every 5 years. I think it's a good idea. That's what I do because a lot of women have undiagnosed hypothyroidism. Either they have like mood changes, dry skin, irregular periods, infertility, and they don't know that they have hypothyroid. So I would order it, get it like done at age 35 and do it every 5 years. It's up to you in the exam whether you want to say that or not. It's not wrong if you don't do it.
Okay.
And then at age 65, you're going to do a urine analysis annually. So those are the blood tests or the general tests. And then, of course, mammogram at age 40, colorectal cancer at age 45, and DEXA at age 65. So that's annual exam, very briefly in a nutshell, which I think are the important things that could be that it could be important. I'm sorry, I got distracted because I'm reading a question and I know we're almost done. So Emily says, I had an example examiner ask me if I recommend RSV vaccine routinely to patients. Are there any official ACOG recommendations on RSV vaccine we should be aware of for the exam? I'm not sure. I will have to look that up. I don't know. Where is Emily? Let me unmute her. Hi, Emily.
Hi.
What did the
Yeah.
exam tell you? What was the answer to this?
She didn't give me an answer. It was in a mock oral, but she specifically brought up the RSV vaccine, and she was asking about the example patient was 55 years old, and I told her that I don't routinely offer this vaccine because I don't know about the safety and efficacy at this point. But I don't know if ACOG has changed any guidelines recently. She didn't actually give me an answer to it when we reviewed everything.
But didn't you ask her or did you forget?
No, I forgot. It was like buried in the hour. And then when we were reviewing it afterwards, we hung up and I thought about it afterwards. I mean, I could reach out to her, but yeah.
Email her and ask her. I'm not sure. I will have to look that up. I don't know everything. Some things I probably don't know. So I'll have to look it up. Did you look it up?
Not yet. I actually forgot until you brought up the vaccine question. So
Then
Thank
now
you.
if you know, share. I don't know when I'm doing this webinar again, but next time share with us, like, or message me, so I can say it in the webinar and everybody can benefit. And if I remember, I will say it myself next time. But we can all look it up. I'm sure we can all Google it and look it up.
Googled it. CDC says adults 60 years of age and older may receive a single dose using shared clinical decision making.
Okay, so it's not really recommended. You just have to tell the patient, ask them if they want it. 60?
60, yeah.
Okay. Thank you.
Thank you.
For that question. We all benefited. Oh my God, there's more questions. Oh God, let me see. Where is the recommendation coming from for yearly EUA? I don't know. I'll have to look that up. I know that, but I don't remember where I read it. I thought that was no longer recommended with a urinary symptom if over age 65. I will have to go and double check. CDC recommends that adults 60 years of age and older may receive a single dose of RSV. Okay, thank you, Tiffany. CDC age 60 at least one time shared decision. Is the RSV going to be recommended for pregnant patients? I don't know. I'm sorry. I'll have to look that up with you guys because I don't want to say something wrong and then you go and say it in the exam. So things that I'm not sure of, I'll look them up. Okay, everybody, it's been great. Thank you so much for being here tonight with me. It is a tough time in your lives. It will get better. You'll get over this. Everything will be okay and it will be history. I wish you all the best. Study well and